a discussion, a healthcare town hall discussion, co-sponsored by the New Hanover County Commission on Women and the League of Women Voters for the Lower Cape Fear. Thank you for joining us tonight. In case you're unfamiliar with the commission, our task is to advocate for women's issues in New Hanover County. I was asked recently what the Women's Commission, how my professional experience has impacted my work on the Women's Commission. And I said, and I think I speak for all of us on the Women's Commission, that so much of what we've identified as a need within our community is based not on professional experience, but on our experience as women and mothers, daughters, and partners and friends. And I think once we approach things from that standpoint, it becomes clear that access to healthcare is not a political issue. It's a community issue, and one that I know I and my fellow speakers take very seriously. So I welcome you tonight and thank you for joining us. Thanks.
Hi, thank you very much for joining us today. This is the League of Women Voters of the Lower Cape Fear. Our mission is to empower the voters and defend democracy. We are a nonpartisan organization, neither supporting nor opposing candidates or political parties. The League of Women Voters of the Lower Cape Fear is an organization fully committed to diversity, equity, and inclusion in principle and in practice. Membership is open to all people, including men. To learn more about our policies and organization or to join us, please visit our website at www.lwblcf.org. We also recognize the tribal lands of the Waccamaw, Siouan, and Indigenous peoples of the Lower Cape Fear. Today we have 4 panelists and firsthand video accounts from people struggling with health inequity. Our chat will be monitored by Velva Jenkins, of the CEO of the YWCA Lower Cape Fear. Please use your Q&A function at the bottom of your screen, and she will read your questions aloud at the end of the presentation. And here is Amanda's story. It's our first video. We'll get that queued up in just a second.
And Patriot missile launcher operator. I served in the United States Army for 6 years. I was a 14 Tango, which is a Patriot missile launcher operator. So my mom was working, and when she was working, she got diagnosed with cancer. It was a colorectal cancer. And she also has Hashimoto's disease, which is a thyroid disease. So she needs to have blood tests and medications, and she needs those every 3 months. While she was with her cancer, she lost her job. So she lost her medical coverage. So there were times where my mom did have to miss her doctor's appointments because at the point in time I didn't have the money and she didn't have any coverage and we didn't know how we were going to pay for it. So that means she wasn't able to get her medications. If she doesn't have her medication, she could die. She was actually cutting her Synthroid pills into 4s just to keep going. So I don't want to lose my mom yet, so I had to open up a credit card so I can just pay for her treatments. It was a burden financially because, I'm on a fixed income, I'm a student, I only receive so much from the VA, and I have 2 kids, house payments, car payments. I have all these bills, and now I had to add my mom's doctor's appointments, her blood tests every 3 months. If we're so worried about our veterans becoming homeless and all that, what I'm having to do is not helping the case, because who knows, what if I get put in such a financial bind that I can't make my house payment? I'm gonna lose my house. My kids will be homeless. My husband will be homeless. I'll be homeless. So that's not helping us at all.
Dave Richard is the Deputy Secretary of North Carolina Medicaid, where he leads the North Carolina's $14 billion Medicaid and North Carolina Health Choice programs for the state's Department of Health and Human Services. Richard's vision for Medicaid is to ensure sustainable, person-centered, and innovative Medicaid program for more than 2 million North Carolinians who use Medicaid. As the programs undergo transformation to even better fit the needs of the state and its residents, he is committed to fundamental goal of improving the health and well-being of all residents. Richard believes the right way to achieve success is to work closely with stakeholders in all aspects of Medicaid. Prior to leaving Medicaid, Richard was the Deputy Secretary for DHHS, Behavioral Health and Developmental Disability Services, and the State-Operated Healthcare Facilities Division. He joined DHHS in May of 2013 as the Director of Division of Mental Health, Intellectual and Developmental Disabilities, and Substance Abuse Services. Richard joined DHHS after leading the ARC of North Carolina, an advocacy and service organization for people with intellectual and developmental disabilities. As its executive director for 24 years, Richard has a bachelor's degree in education from Louisiana State University. And welcome to you, Dave.
To try to work on all the technical things here to get this right. I'm gonna try to share a screen now, make sure we get that right. So give me 1 second.
Sure.
And I think we get it up. There we go. And then we'll do the broader one. Now, of course, something would happen and that doesn't work right. So we may have to leave it in this version because it's not working the way I want it to. So I'm just going to get it a little bit larger and then try to do that. I apologize. And, all right. So why don't we start from here? Here we go, finally. First of all, thank you for inviting me to be with you tonight. And Marla, thanks for the introduction. What I hope to do is to show you a series of slides and talk a little bit about where we are in North Carolina, what we see from Medicaid, but also from what we would like to see in terms of coverage for people in North Carolina. As Merle mentioned, I've been with Medicaid for almost 6 years. And since I've come to the state, I came in a McCrory administration and stayed through the Cooper administration. Expansion has been on the conversation about Medicaid and our services ever since then. And I think most of you know that the conversation about expansion has often died in the General Assembly, as Governor Cooper has just tried to push that through, and many other members of the General Assembly have done that. What I'd like to talk about today is a little bit about what the reality is in our state, some of the things that the governor is attempting to do to try to move that forward, but also a little bit about the conversation, and I think is so important for us all to have as we're speaking with elected officials as we move forward. I wanted to throw this slide up. This is really a little bit about what Medicaid looks like today. And I think the most important thing to see when you look at this slide is that to be on Medicaid, to receive the Medicaid benefits, for most people, it means you have to be very, very poor. It's not a program. I think there's a lot of misconceptions often about Medicaid, about what happens when you think about the parents and caretakers of children under 18, and at 42% of the poverty level, it's hard to imagine that anybody's living at those dollar amounts. But we're not, when people are on Medicaid, we're not speaking about people unless it's a specialty program around some of our disability services. we're speaking about people that really do not have much money. So when we begin thinking about coverage, I think it's really important to think about where we start from with the Medicaid program. So when we think in North Carolina about health coverage, we often talk about if we were going to expand Medicaid, we'd probably cover some 600,000 people inside the program. But it's important to note that we have a significant number of people that are uninsured in North Carolina. And these are Census Bureau data. We might have other slides that show a little bit different as we go through, but in general, there's an awful lot of folks in the state that don't have coverage itself. And what we know, I think what you know, is that although coverage doesn't necessarily buy you health, without coverage, it's going to be almost impossible for people to have health. And in this slide, we show significant what we look like compared to the rest of the country, what we look like compared to expansion states in terms of how many people are covered. And obviously, when a state expands Medicaid, more people are covered, but it's a pretty good illustration here. And also shows you where people get those coverage from that have coverage in the state. So just a quick slide there. And I should mention this, I'll mention it at the end, but here is that these slides all are on a website of Duke Margolis, which is an organization that has helped us. It's a policy organization that has helped us convene a health policy group, healthcare policy group, the governor's healthcare policy group, that just finished its work. And today, actually, a press release came out indicating some of the basic principles that came out of that group. And I'll mention that at the end, but I want to make sure I gave credit to where these slides came from. So when you think about 19 to 64-year-olds and what does it really look like in terms of the expansion states and where people are. And I think if you see this, obviously, we are, in terms of an organization, the 6th highest uninsured rate in 2019 inside of North Carolina. That I don't know about you, but it pains me to see that. We as a state, we strive always to be at the top of everything we can be. And clearly this is for North Carolina, I think something that we hope all of our residents and citizens begin to believe that has to change in our state as we go forward. But 6th highest uninsured rate in the country. Here's the folks that are uninsured. So if you look at the bracket at the bottom, if you think about, that's the Medicaid expansion group, right? That 100% to 50% to 138% of poverty. And we see that, the folks that really need coverage are folks that have or the poorest in our state. And then we get obviously to a larger, when people get above 100%, those folks in that gap, right? But think about that number. It's $36,000 for a family of 4 that meet that 100% or 138% of federal poverty level. And I think there's an incredible misconception of policymakers and other folks that somehow that if you were to expand Medicaid, that people will receive that, or people that are that have money or making a lot of money, and it will hopefully throughout the night show that many myths exist about who the expansion population would be. 28% of people at work don't have access to employer medical benefits. Now, this is a national stat, but I think it's also something that sort of brings home the point, right? When we think about what coverage is about, is that we have, and I don't think anyone is suggesting that we shouldn't have an employer-based healthcare system. That's not what is proposed, but it does not get to a large number of people that actually are working. There are many businesses that don't cover or don't have that ability to cover. And here you can see is that we've broken it down by multiple places, but it makes perfect sense, right? For folks that are in more white collar jobs and management professional jobs, much higher access to coverage. People with higher income, much higher access to coverage. And then for employer-based plans, if you have a lot of workers, much higher access to coverage. And I think that's another thing that we need to continue to point out as we're thinking about our advocacy around how to improve coverage in North Carolina and then expansion. Here's I think an important slide to think about, where are the folks that are uninsured? Where do they work, right? The people that are uninsured workers. Well, it's across all sectors, but like nursing home and home health is a really critical sector that we're there. Clothing store workers, hotel lodge workers, restaurant workers, hair cutters, childcare workers. I think if you think about this population, right, that we named, there are things that stick out, right? Often the folks in these groups are historically marginalized populations, and often they're women. And so it's a population that when you look at these workers, we really need to think about the equity side of it, which I know this conversation's about, and where we find ourselves in terms of looking at who are the folks that work and who are uninsured inside of in our country. Obviously, the expansion states have a much lower percent of uninsured adults as we go forward. I think what's really interesting about this list is that often when people think about expansion states, they think about those states that aren't southern states or aren't states that we think about have a lot of poverty. But clearly, Kentucky and Arkansas are states that that would be states that you would think about that really need that expansion. And again, when I think about North Carolina, I would like to think that we can do things that are similar to Arkansas. We ought to be able to be in that place, right? That we shouldn't be a state that's behind other states that are these southern states and other states that typically folks would not think about in terms of expansion states. Here's another way to think about who are the folks that would be eligible for expansion. This is beyond the worker side, but more than half of the uninsured are low-income adults under 40. The employment industries we talked about, right? There's that 24% are unemployed, 76% are employed. That there, race and ethnicity. I'm sorry, if you know clearly, we have an issue around our racial biases and how it infects in healthcare, and we know what healthcare makes a difference for. And then if you look at the uninsured here, 1 in 3 uninsured eligible people are parents of children under the age 18. Again, often another myth that people have is that those folks are there. And in gender, we mentioned is that primarily women are the low-income uninsured in across. Often people think about expansion, and we don't talk about the economic benefits, and we'll talk about those in a minute. But one of the things that's really important to think about is that our hospital systems in North Carolina provide $1.8 billion of uncompensated care. When we think about how to pay for expansion in the future, one way to do it is assessments on hospitals. And people would say, well, why would that make any sense? Why would you assess, and why would hospitals be willing to do that? Well, it's because right now we have so many folks that walk through the doors of hospitals where they have to be treated. So they have a responsibility to do that. And if you look at how much uncompensated care is provided, if folks had health insurance, that would really significantly dip into that issue. So it's not only, when you think about our health system, it's about the people that really need services, but it's also about how we sustain our health systems in the future. And then when you think about the people that would be eligible for Medicaid expansion, when you look at this map, what you see clearly is those folks in rural counties. We have a much higher percentage of folks that would be eligible for Medicaid expansion. Again, I think often the myth is that this is really about urban areas, and that's where the expansion population would be. But the reality is maybe the population and numbers are larger in urban areas, but when you think about the percentages of people that would benefit expansion are in these rural areas. Again, I think that's something that we have to make sure that we're talking to our policymakers about, and they understand it. For those of you, obviously in the counties around Wilmington that are rural, but anybody that's here from across the state. Let me say a few words about this and about a little bit about the politics of expansion and coverage in North Carolina. I think you all know that, and there are a lot of reasons why people support expansion, and there are a lot of reasons why people don't. What I like to think is having had the opportunity to spend a lot of time with members of the General Assembly, is that it's easy to characterize people that vote against expansion as people that don't care about health. That's just not true. There are a lot of people who will have never voted for expansion, who haven't chosen to do that, who really do care deeply about the health of their citizens. But for some reason, whether it's because they believe that the federal government may not keep its commitment to North Carolina, other states, in terms of the percentage of dollars they would pay for expansion, or a deep-held belief about personal responsibility, about work requirements and those things that we often talk about. What I believe is that most members in our General Assembly, when you have the real conversations with them about what they want to achieve, they want healthy citizens. They want the folks in their districts to be healthy. They may come at it from very different perspectives than someone who believes that full expansion, like I do, is the best answer for our state. But I think our opportunity during this year is to really begin to have conversations with people about coverage. That's what the North Carolina Council on Healthcare Coverage was about. It was appointed by the governor. It was a bipartisan group of folks, including legislators from both Democrat and Republican side, but business folks, advocates, a wide range of individuals. And what the governor asked folks to do is not to come in to talk about expansion, but to come in to see if there were a set of principles that they could agree upon about how we could cover more North Carolinians. And clearly, expansion is one of those options. But other things that people talked about were really, how do we expand telehealth coverage? How do we really think about behavioral health in a different way? How do we look at potentials for employer-sponsored, association-sponsored health plans? Other ideas that people brought to the table. Now, some of those we know can't work because of maybe federal things that are in the way of those. Some of them that will not reach the number of people we have. But what I was so impressed with is that the folks on this committee, again, from all walks of life, all different places, is that there was no disagreement that we should cover as many North Carolinians as possible. And I believe when you begin, tell you the principles released today, and you can go to this website and you'll see those principles. You'll be able to look at all of the information that came from there. But as you talk to people and as you look at these principles, what it gives me hope about is that I believe that our business community, our legislators, our county commissioners, all of our advocates, and I can tell you, obviously, from the governor's standpoint and the governor's team, is that there is a strong desire that we in North Carolina really make a difference this year, significantly change the way we think about this, and finally come to an agreement about a way to cover more North Carolina citizens. What I believe is expansion has got to be one of those key components of that. And I think we may have some help from the federal government. So if the current version of, I forget what they call the federal law that's going past, but does the stimulus package passes, inside of that is an enticement for all states that haven't expanded, which includes for North Carolina a 5% increase in the federal participation in the Medicaid program for all of the Medicaid program. In North Carolina, that's $1.7 billion that we would receive over 2 years. And our estimates currently is that if we were to expand Medicaid, that would be $700 million. So North Carolina would have a windfall of over $1 billion of those dollars, which we could invest in other healthcare related items of those 2 years, and then slowly ratchet to where we use asepsis on the hospitals and taxes on our health insurers to be able to pay to 10% of Medicaid expansion, which I think is the best deal you can think about, is that the North Carolina taxpayers would not have to add additional money from state resources to pay for this expansion to cover 600,000 people. So I'll stop there, and I know there's another story coming after that, and really look forward to the opportunity for our conversations to happen after all the presenters. Thank you.
David, can you unshare your screen?
That's what the problem was. I apologize. I can, but I've got to, I'm sorry, it's moved all over the place. There we go. There we go. I apologize.
Another patient, which I think is equally tragic, was a young man who was starting out as an independent contractor as an electrician. And so he was just starting out his company. He was in his early 20s when he started losing his hearing in both of his ears. And we were finally able to get an MRI because he didn't have insurance. And the MRI showed that he had tumors in both of his ears called acoustic neuromas. And it turns out he has a condition called neurofibromatosis type 2. people develop multiple tumors in their spine and in their brain and the nerves. And the hallmark of it is that they get tumors in both ears and go deaf and have horrible dizziness from it. So he had to wait, and he disappeared for a couple years, and he came in with absolutely gigantic tumors with serious brain stem compression, very, very sick, near comatose, and required multiple surgeries to remove these tumors. And now he's completely deaf and disabled for life, and with chronic pain from the spine tumors that he's still not able to get taken out. He would have been able to have them removed years ago when they were smaller, but now they're too big and would cause spinal cord injury, which would leave him quadriplegic if he had it. So now he has to live in excruciating chronic pain from these tumors when this all could have been taken care of much earlier. It's a horrible feeling when these patients come in and they look to you for an answer, and you say, well, this is what you have this diagnosis, this is how it's treated, but you can't have that. And it's really hard having a young man burst into tears in your office because you want to help him. He was in with his mother, and his mother had, she was in tears. And it's just an incredibly emotional thing. And we realized if he was just lived in another state, he would have been able to have this taken care of.
You're muted, Marla.
Thanks. Sorry about that. Michelle Gady, JD, is the founder and president of Atraumatis Limited Liability Corporation. She takes nearly 20 years experience in health law and policy, program design and implementation, value-based care, and change management, and puts it to work for Atraumatis' partners who are trying to succeed during this time of dramatic transformation within the U.S. healthcare system. The words used most often to describe her are, she gets things done. Yes, she does. Michelle fully understands the intricate process of turning policy into law and understands the need to balance competing forces in order to succeed. Michelle has been intimately involved in the creation and passage of major healthcare laws, including the Affordable Care Act, as health counsel to a senator member of the U.S. House of Representatives Ways and Means Committee. She has honed her ability to think strategically and creatively in her prior roles with healthcare policy and advocacy organizations, such as Families USA and the Medicare Rights Center. She brings these skills to all Atraumatis partners. Michelle earned her Juris Doctor from the Quinnipiac University School of Law and a bachelor's degree in rehabilitation services from Springfield College. Outside of leading the Atraumatis team, Michelle serves as a board member for both the Cape Fear Literacy Council and A Safe Place, and is a member of the American College of Healthcare Executives and American Health Law Association. Welcome, Michelle.
Thank you, Marla. This evening, I want to talk to you about two things. One is the importance of Medicaid, and then what are the benefits of Medicaid expansion. Since 1965, Medicaid has grown in its importance to individuals, to healthcare providers, and our communities. And my perspective is the importance of Medicaid today really cannot be overstated. The Medicaid program covers more than 70 million people across the country, and in North Carolina, it covers over 2 million people. It accounts for 20% of healthcare expenditures nationally. It pays for over 60% of long-term care nationally, and probably is the single source of long-term care coverage, meaningful long-term care coverage in the country. It's the largest payer of behavioral health care services, including covering treatment for almost 40% of adults with opioid misuse disorder. And it covers more than 50% of births across the country. And this all holds true for North Carolina as well. Medicaid has resulted in significant improvements in health since it was enacted. For example, in 1960, the infant mortality rate was 26 per 1,000 live births. In 2018, it was 5.7 per 1,000 live births. Medicaid also enables the private insurance market and the Medicare market to operate more efficiently and affordably. So for example, by providing coverage to individuals with disabilities, Medicaid alleviates the cost that private insurers would incur if individuals with disabilities had to otherwise seek coverage from private insurers. And this is what we talk about with the importance of Medicaid and its role in creating market efficiencies. Medicaid is also a vital component of our social safety net, keeping millions of Americans from incurring large medical debt and further increasing rates of poverty. And of course, we can't gloss over the fact that all of this comes at a significantly reduced price to the states because the majority of the cost is covered by federal dollars. So while the Medicaid program costs about $15 billion annually in North Carolina, about $4 billion, or 1/3, is what is paid by state dollars, and the remaining $11 billion is paid by federal dollars. So absent the Medicaid program, the state pays for all of the services or people go without. So Medicaid has existed for quite some time. It principally covers, what we think about as moms and kids, folks who are on Medicaid, on Medicare, who are dually eligible, and people with disabilities. So with the Affordable Care Act, we then had the opportunity to expand Medicaid to all folks, regardless of their gender, regardless of their disability status. It really was based on their income and ensuring that all folks with low income had access to coverage. And so, the question, because in the Affordable Care Act, it was a mandate, then the Supreme Court intervened and it became an option. And so the question became to expand or not to expand. And as of January of this year, we have 38 states in the District of Columbia that have in fact expanded Medicaid. We have 12 states that still haven't, and that's Wyoming, South Dakota, Wisconsin, Kansas, Texas, Tennessee, Mississippi, Alabama, Georgia, Florida, South Carolina, and of course, North Carolina. And so while the vast majority of the states have in fact expanded, we're left with the question of what is stopping the remaining 12 states from taking advantage of considerable federal funding in order to extend health insurance to low-income adults in their states. So there has to be some reason. And I keep asking that question, but unfortunately so far, I've actually not been able to find a legitimate good reason for not expanding Medicaid. And in fact, there is substantial evidence that expansion has significant benefits to the states, to individuals, to businesses, and to the general state economy. In fact, there's over 400 studies that show wide-ranging positive impact as a result of expansion. So these include improved healthcare access and outcomes, increased financial security and reduction in poverty, healthcare market efficiencies and stabilization, increased economic growth, and state budget savings. And so I'll spend some time talking through each of these. So Medicaid expansion is associated with significant reductions in the uninsured rate. And so for women between 2018 and 2019, women between the age of 18 and 65 saw a drop in their uninsured rate from 18 to 11%. Women earning less than 200% of the federal poverty saw a 15% reduction in the uninsured rate. And while some of that reduction was related to other components of the Affordable Care Act, a significant portion of that reduction resulted from the Medicaid expansion. Unfortunately, we continue to have about 12% of women who fall into the coverage gap nationally. And in North Carolina, of those who are in the coverage gap, 53% of them are women. So this means closing the coverage gap will have significant health benefits for women. In addition, a recent study from Georgetown University Health Policy Institute found that while Medicaid expansion was meant for adults and increasing access to insurance for adults, it actually has led to increased coverage for children as well. And this is because when parents gain coverage, they are more likely to enroll their children in coverage. The same study found that between 2016 and 2019, the child uninsured rate in non-expansion states grew at nearly 3 times the rate of expansion states. And in North Carolina, the rate of uninsured children is just slightly above the national average at about 5.8%, but continues to grow. And so this increased access to coverage means that people have increased access to more timely and appropriate care. States that have expanded Medicaid have seen increased access to care, which means people are using preventative services and have consistent care for chronic conditions. If North Carolina expanded Medicaid, studies show there were about 50,000 people with depression who would receive treatment. Over 27,000 people with diabetes could access medication, and there would be significant increases in access to preventive care, such as more than 12,000 mammograms. And as a result of this increased access to timely and appropriate care, states that expanded Medicaid have seen a reduction in preventable mortality from disease-related deaths and overdoses. And estimates show that if North Carolina expanded, we would have a reduction of 1,000 to 2,000 per year in preventable deaths. In addition, Medicaid expansion has led to reductions in disparities based on race and ethnicity, education levels, employment status, and insurance type, and income. And we know right now we have a long way to go to addressing disparities, particularly racial and ethnic disparities, but Medicaid expansion will be a central component to doing that. Just as in 1965, when the original Medicaid program was enacted, Medicaid expansion is also closely associated with increasing personal financial security. And this is because Medicaid expansion leads to significant reductions in medical debt, as well as the size of medical debt, which in turn reduces the number of medical debt-related bankruptcies. Studies show that if North Carolina expanded, almost 15,000 fewer people would face catastrophic medical expenditures, which is a primary driver of medical debt. Medicaid expansion has also been shown to increase employment, and employees have fewer missed days of work, which just makes sense because when employees are healthier and not concerned with issues of financial insecurity, such as evictions or food insecurities, they are better able to work. Further, improved access to substance use or opioid use disorder treatment, which occurs under Medicaid expansion, enables working-aged adults to receive the treatment they need and return to the workforce. And in the greater Wilmington area, one of the areas of the country hit most by the opioid epidemic, this is critically important. Next are market efficiencies that mostly only people like me find fascinating. But expanding Medicaid makes healthcare more affordable for everyone and improves the sustainability of the healthcare system, which basically is all I mean when I say improving market efficiencies. This is because Medicaid, and specifically the federal government, covers the cost of those least able to afford insurance premiums and most likely to forego insurance. I think, we all need to understand that just because somebody isn't insured doesn't mean that they don't utilize health services. It's more likely, though, that they use expensive crisis care, which I think many of the videos we're seeing tonight are demonstrating to us. So balancing out uncompensated care is a challenge for many hospitals, particularly small rural nonprofit hospitals. And we've seen in North Carolina quite a few of our small rural nonprofit hospitals closing. In states with Medicaid expansion, they have seen instead increases in their operating margins and overall financial performance. So between 2013 and 2015, in the states that expanded Medicaid, uncompensated care was reduced by $6.2 billion. This improved the financial sustainability of the hospitals, which resulted in fewer closures, particularly in the rural areas. There's also evidence that expanding Medicaid in a state reduces the private insurance premiums of the plans that are on the ACA marketplaces, and it also leads to greater regional stabilization in premium pricing in the private and commercial market. So this is one of those areas of helping people understand that expanding Medicaid isn't just good for those who then get access to Medicaid. It really does have a system-wide impact, and what's good for my neighbor becomes good for me. Medicaid expansion also results in state budget savings. Medicaid expansion comes, as I said, with a significant influx in federal dollars. If North Carolina had expanded Medicaid in 2019, the state would have received almost $12 billion in federal funding between 2020 and 2022. And this is because, as Dave mentioned, the federal government pays 90% of the cost of expanding Medicaid. If the most recent COVID relief legislation passes, that gets even more enticing. And so this federal funding then supplants certain state spending, which creates significant savings for the state, freeing up dollars to be spent elsewhere. So one estimate has said that over a 2-year period, if North Carolina expanded, it would have about $100 million in saved state dollars. This is not only from services that are currently covered by state dollars being covered by Medicaid dollars, but also as a result of reductions in uncompensated care, because the state pays hospitals to reduce some of their uncompensated care. And then really very importantly is the economic growth. So in addition to state budget savings, the influx of federal funding also infuses money into the state's economy. And so we can look at states that have expanded to see what their experience has been. And if you look at Louisiana, after expanding Medicaid, they saw a $3.48 billion business activity increase, over 19,000 new jobs, and about $1.2 billion in new personal earnings. So if North Carolina expands, estimates show that there's an influx potentially of almost 40,000 new jobs. And these aren't just healthcare jobs. These are jobs across industries. There's an increase in gross state product between $2 and $3 billion, and a potential increase in state and county revenue over a 3-year period. Bringing it local in New Hanover County, estimates show that if the state expands, we are looking at almost $200 million in new economic activity and almost $3 million in new county revenue. And I personally find it really hard to argue with numbers like that. And so when we look at expanding Medicaid, it really is good for all. It's not just good for those who have Medicaid or would get Medicaid. Medicaid expansion has been, from my perspective, unequivocally demonstrated in study after study across many states over many years to improve the sustainability of healthcare systems, to create more stable and affordable private insurance. It increases job opportunities, and it certainly leads to healthier communities. And so I think we're going to hear one more story.
I got a letter in the mail telling me that I was no longer eligible for Medicaid, and my son would still be covered because I was still making less than $2,400 a month. But the minute I made over $2,400, my son would be disqualified. That's a hard thing for me because my son has type 1 diabetes. And we've been talking about that. We said, what happens when you are no longer qualified with mommy? What are you going to do? He said, Mommy, I don't know. My only other option is to send him back home because Chicago ain't like North Carolina, and he'll get health care. That's sad that I'll have to send my baby all them hours away. I moved from Chicago because I didn't want all the stuff that's happening there to infiltrate him. And the reality is, guess where medically he'll get help. You know, I wish I could be in front of a committee to talk to some legislators and let them hear from a real parent's heart about how their insensitive choices are putting lives at stake. I would look them dead in their eyes and say, if it was your baby, what would you do?
Jenny Black is the President and Chief Executive Officer of Planned Parenthood South Atlantic, which covers Virginia, West Virginia, North Carolina, and South Carolina. In 2017, Jenny was appointed by Governor Cooper as the chair of the North Carolina Council for Women and Youth Involvement. Jenny is a 12th generation North Carolinian and resides in Raleigh.
Hey, everybody. Thank you, Catherine. It truly is a privilege to chair the Council for Women and Youth Involvement. And, you know, as Catherine said, our mission is to advise the governor, the legislature, and state agencies on issues impacting women and youth in North Carolina. We also manage a grant program for sexual assault and domestic violence providers, as well as coordinate a statewide network of women's commissions and youth councils. And I got to give you a shout out, Catherine, for launching one of our newer commissions in New Hanover County. So thank you for your leadership there. It's a real privilege to support you in that. So one of the big scopes of work that the Council for Women is responsible for is that we produce annual status of women reports. And we look at 4 major areas of quality of life for women in North Carolina. Health and wellness, on which we score a D. Employment and earnings, in which we score a C, which is an improvement over a D the last time we produced our employment and earnings report. Political participation, on which we score a D, and our upcoming report on poverty and opportunity. And I really want to encourage everyone to check out the Council for Women and Youth Involvement website, where all of these data-rich reports are available to you in full. So based on these data-rich and substantive reports, we routinely make policy recommendations to improve the quality of life for women in North Carolina. It's the Council's stated and adopted goal to make North Carolina the best place in the United States to be a woman. And that goal is very achievable. We believe we have a lot of work to do, as you can see, but we believe the goal is very, very achievable given all of the rich assets that North Carolina has to work with. I don't know about you, but C's and D's don't cut it in my house, and they surely shouldn't cut it for the women in our state. So that's just a little bit of a level set for what the Council for Women is. So recognizing that the baseline quality of life for women in North Carolina was already pretty problematic in our view, we were really interested in how women were faring during the pandemic, right? COVID came along and we thought, oh my gosh, this is not likely to be improving the situation much for North Carolina's women. So in the summer of 2020, we decided to work on this supplemental report to show whether our baseline for women was getting worse or better. And in particular, we were really interested in whether BIPOC women were being impacted disproportionately. So our council is made up of women from all demographics and from all points all over the state. So we formed an internal working group and we created an interview list of women representing different races, socioeconomic status, professions that are primarily staffed by women to give us just kind of a peek into their lived experiences. And while we were very intentional to present an intersectional analysis that spotlights communities and demographics most marginalized by the intersecting forces of racism and sexism, we can reasonably assume that the people and organizations that we had access to, who are kind of within our spheres, were willing and able to give us their valuable time, are probably a degree or even 2 degrees removed from the many women who simply weren't in our periphery, who were probably even more impacted. So the takeaway from all of that is that we really encourage North Carolina leaders to consider this a cross-section of stories as best case scenario and go from there. So early in the pandemic, we found a grossly disproportionate impact on women and people of color. Black North Carolinians are 22% of the population, but we're 30% of COVID cases. Latinx North Carolinians are 10% of our population, but we're 31% of COVID cases. And in the words of our governor, the pandemic exacerbated those disparities felt by people of color. Now, to be clear, we have seen some leveling off since then, thanks to strong mitigation efforts done by the state. So we applaud that. And still, women represent 53% of our state's COVID cases today. Now, one of the challenges in our state's data around COVID is that it does not take this intersectional view that we were really interested in looking at. So while I can tell you how many women, I don't know exactly how many women of color. We know that women represent more than one identity, and that has been a real challenge in putting together this report using data. So one of our recommendations to come out of this report is to make that data more intersectional, more transparent, and a little bit more accessible so that we can have a clearer view into what exactly is happening for the BIPOC women of North Carolina. And so we strongly recommend expanding Medicaid and mandating paid leave. Medicaid expansion will ensure that many of these women who are getting sick are able to get the care that they need and even more readily access the preventative care. Now, furthermore, 94% of domestic violence service providers in North Carolina reported unexpected and sharply rising costs associated with the pandemic, while 75% of service providers reported an increased demand for those services. Now, prior to the CARES Act, which increased funding for domestic violence by $6 million and sexual assault by $6 million, the state's budget had not increased in over 10 years. So that has left resource-strapped nonprofits providing services that have not been able to keep pace with demand. So one of our recommendations is to sustain this level of funding for domestic violence and sexual assault agencies and provide emergency support for child welfare. Now, according to the Census Bureau, 19% of North Carolina women, 22% of Black North Carolinians, and 13% of Latinx North Carolinians have applied for unemployment benefits since March. Because undocumented people cannot receive unemployment benefits, we believe that this number does not accurately represent the total number of Latinx people in need of benefits. Census data indicate that since May, 43% of Latinx households, 51% of Black families, and 36% of white families have lost employment income, with over 1 million North Carolinians food insecure. Black and Latinx North Carolinians are 2 to 3 times as likely to be hungry than their white counterparts. Now, historically underutilized businesses or businesses owned by a woman or racial ethnic minority account for 58% of North Carolina's small businesses, 90% of which indicated COVID-19 had significantly impacted their business, as reported in the findings of a June executive order. And as early as May, national data showed a 41% drop in African American business owners, 32% drop in Latinx business owners, 26% drop in Asian business owners, and a 25% drop in women-owned businesses, a trend that is verified by the North Carolina women business leaders with whom we spoke. So we really want to see investments in the care economy. That's childcare, elder care, sick care. We're seeing indications that the Biden administration may be putting some real resources into this, and our advice is to not leave federal dollars on the table, as we have done here with Medicaid expansion. Now, once again, our pre-pandemic research finds that the baseline for North Carolina's women is poor on civic and political life. Between 2015 and 2020, North Carolina women's participation actually decreased in most areas, receiving a D grade compared to other states, with an increase in only 2 areas. One, the share of women who voted increased slightly, and two, the share of women in the North Carolina State House of Representatives increased to 27.5%. Remember, we're over half the population. The share of women who registered to vote actually declined, though, from 71% to 68% before the pandemic. And the dual threats of exposure concerns associated with the virus and very real concerns that people of color expressed around their safety presented a real risk that further dampened civic engagement. The share of women representing North Carolina in the US House of Representatives decreased between 2015 and 2020 from 23% to 15%. So our recommendations are to center BIPOC women in any COVID response, deal with those disparities that existed in their representation before the pandemic. And by the way, we think it's time to professionalize the legislature. By paying a living wage to serve, it may very well be more attractive to a broader cross-section of people. Now, we also recognize that not all is bad in the pandemic, and we really wanted to explore what innovations were working well. We've heard a lot about what hasn't been working well in the pandemic for women, and we wanted to really explore whether or not there are anything that women would like to keep in post-COVID times. And we heard from women loud and clear that teleworking has offered a great deal of flexibility for women to better juggle our many competing demands. And we'd like to keep that option available. It didn't mean that our demands decreased, it just felt maybe a little bit more doable. So we recommend employer incentives to support more teleworking opportunities. And we'd like to see more policies that encourage or mandate paid leave and those care incentives that we talked about. And I think we'd all agree that the state's unemployment systems need attention to eligibility, accessibility, and duration, all of which intertwine with Medicaid eligibility. Lastly, we strongly recommend applying a gender and racial equity lens to all response and recovery plans going forward. The governor rightly created the Andrea Harris Task Force to create a set of recommendations that addresses the disproportionate impact on people of color in our state, and that is great. They have incorporated 7 of our recommendations that specifically center Black and Brown women into their list of recommendations. We strongly believe that we can't simply go back to our old way of life. We have to create a better post-COVID reality for our women if we ever hope to bring our grades up from C's and D's to the A quality of life we all know should be a reality for every one of North Carolina's women. Now, I think we have another video story to hear.
My entire life, my family's been in medical debt. I literally think about my health problems and my future and just the medical debt that my family's in every day. It never goes away. It's not right. It's just not. And I don't know who decided that being healthy was a privilege. I am 27. When I turned 26, I aged out of the state healthcare policy that I was on because of my father's work. And I have not been able to get any kind of insurance since then. I'm currently unemployed because of COVID. I worked in a restaurant. My boss, understanding of my situation, my whole family's high risk. My dad has asthma. My mom with her autoimmune diseases, mine. My boss sent me home before we even had lockdown. But even when I was working, I didn't qualify for Medicaid or the ACA. And so I have been sitting on no insurance for almost 2 years now. And that's a terrifying prospect in the middle of a global pandemic when you're a high-risk individual. I have clinical depression. I am recovering from an eating disorder, and I can't go to therapy. I also have to have reconstructive surgery on my nose, and That cannot happen until I have some sort of medical coverage. And if I don't have this procedure done, I will lose my ability to breathe through my nose and to smell by the time I'm 40. If we had Medicaid expansion in this state, so many problems would be solved. And if we don't have leadership in place who's willing to talk about that, who's willing to advocate for it, it's going to stay that way. And people are going to keep dying. I just think it's important that people realize that. And I think it's important that we do all that we can to convince people to take the steps needed to make that change happen.
Nicole Dozier is a 24-year veteran of the North Carolina Justice Center and the director of the Health Advocacy Project, which advocates throughout the state for affordable, equitable, and quality health care for all our citizens. She is also serving her second term as mayor pro tempore of Apex, North Carolina, of the Apex Town Council, and is a North Carolina State Bar certified paralegal. Nicole has a ton of honors on her biography. My favorite, though, is that she is featured in UNC Chapel Hill, of which she is an alumni, their online Women with Moxie Oral History Project. Thank you for joining us.
Thank you so much, everyone. Thank you for that kind introduction, Catherine. So thanks so much for running the slides for me, Linda. I agree with everything that was already said by the panelists that I'm honored to serve down here with. And so I just want to talk a little bit more about Medicaid expansion in our state. You can see, as others have already talked about, how we're one of those holdout states. And I want you to note that it's interesting that we have this southern block of states, including some others, but, it's interesting to note, and I'll talk a little bit more about that in a moment. Next slide. Yeah, and I won't go into detail because it's already been covered, but just thinking about how people, when we used to travel across the state before COVID, and we would say, all people with low incomes in North Carolina are not covered under Medicaid, and it would just be a gasp in the room because people just don't realize that. And it doesn't make sense that we've created this, in quotes, deserving categories of people. So you can literally have someone with zero income, with no minor child in the home, and have no health coverage. Which to me, I just think is just cruel. And so we can go to the next slide. And so if you click the next one, I think you'll see some more of the things. So we can see this number, we've used this number for a long time, saying over 500,000 people, but really that number has really increased, and it's well over 680,000 people. Because as we continue to hold out and not provide coverage for people, even before the pandemic, then of course we continue to have more people in the gap. And as you see, when people have substance use disorders, and end up having disorders and things that may allow them to not access the healthcare system, they end up in the justice system. And so sometimes we get to think about what we're doing and how we're pushing people into prisons and jails and separating families, when perhaps some of the issues that people are having were just related to making sure they can have access to healthcare. Next slide. And so for me, I just want to speak a little bit about, there is, in my opinion, ideological resistance to this, because you notice that none of the panelists could actually explain why we are doing this. And some people say there's got to be some reason why, there's got to be some economic reason why. Well, there's all the stories in the world and all the reasons why, over 500,000 reasons why we should expand Medicaid and should provide coverage for people. None of us have been able to find a real reason why we shouldn't. So I'm going to give you even more information as to why that was already covered by my peers here, is that, our opportunity right now is at the federal level. It's the House Energy Commerce Committee reconciliation proposal. It's part of the COVID relief package that you're hearing about now, that it would encourage the non-expansion, I'm going to call them holdout states, to take up expansion by providing an additional temporary fiscal incentive for states to newly implement an ACA Medicaid expansion. So clear under this proposal, the states would receive the 90% ACA match for the expansion population. For states that expanded Medicaid, and gaining millions of coverage, the thing though is that that what we would, we just couldn't believe when we ran the numbers and asked other folks across the country to look at this with us, is that the 5% percentage point increase as part of this proposal is huge for us. So we're talking about $2.4 billion. And this is beyond what we've been speaking about before related to what Medicaid expansion would do for our state. We're talking about the entire program. So right now, we know it's a partnership program that the federal government pays about 67% of the cost of what Medicaid costs. You're talking about during a public health emergency, they added 6.2 to that percentage to that. So we're getting more money to cover folks who are, for COVID, for example, the testing and treatment was free under Medicaid for people who are uninsured. But when you're talking about this 5% point increase, you're talking about for the full Medicaid program and not just, so the money coming in is not for just the Medicaid expansion population, which is a very important population to talk about, but it's for the entire Medicaid population for the state. So that incentivizes all of us to get our ducks in a row and let's accept this Medicaid expansion. And this is for 2 years. You got 2 years to do this. And so we've already left $4.9 million a day, every day that we're losing for not expanding Medicaid. If we don't do this, we're going to be in the same situation where we keep waiting and waiting to bring money down from the federal government that we need. So there's been 2 estimates. And so you can see it's Kaiser Family Foundation and CBPP, Center on Budget and Policy Priorities. And the traditional match rate that would offset these increased costs for every state, the amount for North Carolina, as I said, we use the number of 2.4 billion, but there's also an estimate of 1.7. I would say that either of those sounds really good to me to come into our state. I think you, Dave, would agree. So looking at the opportunity, when you look at it in this visualization, it's just hard to look away. You look at where we are in North Carolina and then our neighbors, South Carolina and Tennessee. This is a lot of money. A lot of money that's on the table if this provision remains in the COVID-19 package, and it's looking like it's a real possibility for us. Next slide. Okay, you can go to the next one. I think I'll cover that too. Thank you. So if you look at this visualization, you can see sort of the rate of uninsurance from 2010. When the law passed to 2018, and just picking a few key counties that are more tier 1 and have significant people of color, you can just see where the uninsured rates were and how, where they end up in Gates and Hertford and Shawan, Bertie and others. And we want to just think about, where we are in this and what we can do for, this is one North Carolina. And we shouldn't have people in more rural communities who need rural hospitals to end up with less health outcomes. Next slide. We can go to the next one. So I wanted to talk a little bit about equity in the vaccine. And you see that, as our other panelists mentioned too, that we're doing better now. But just looking at the percentage for African Americans and looking at, our percentage of being in North Carolina, and then the cases at 20%, the deaths at 26%, and the population getting vaccinated is back up to 10%. So we've got some work to do, but I think there is real momentum from the state and from faith leaders and advocates and people just saying I got my shot, and this is not something that is harmful to people. And I understand some hesitation in my community. I understand that we have reasons for that. That goes back to history. But I think that we're all working towards one goal of getting us all covered so we can go back to some form of what people call normalcy, but also embracing some of the things that we've learned that need to be changed. Next slide. Looking at the Hispanic Latinx community, the same thing. You look at only 3% have been vaccinated. Look at the cases at 23%, the deaths at 8%, and they're only 10% of the population. So you think about what that means, and also when you think about who is doing some of the frontline jobs, particularly those that are called essential workers, and who are at the mercy of how we behave when we go in stores to get our essential goods. Next slide. And then look at the white population we have. So how they're way out front, you know, white people are way out front is like 82% of being vaccinated, 62% of the cases. So that's really telling as to who has been able to access the vaccine so far. But again, just showing that we need to do more and more to get us to where these, it's more equitable. Next slide. And then Asian Pacific Islander, we're looking at 3% vaccinated, but they're 3% of the population. So that percentage is a little more in line. Next slide. All right. So I wanted to just point out to people that, you know, people who lost jobs during the COVID-19 downturn were over 1 million. And those who lost their employer sponsored health coverage were like half of that. And so, but look at those 193,000 people who we found that were unable to get other insurance. So that's, you know, that's why these numbers are getting larger and larger, people in the coverage gap, because people here are joining those folks that we've been trying to push for so many years. Next slide. Okay, and so what I want to end with before we go into, I guess, the Q&A all is that what we ended up doing is trying to create a block of southern states to attack this issue together. And so the 8 southern states got together. We had a vigil and on October 1st. And we just wanted people to see all across the country how the southern states have been left behind and think about the historical context of that. And that we're going to continue. And I was going to give you, I have some of the numbers up, which will surprise you, maybe, but maybe not, about how we were just saying really that, you know, America can't recover if the South isn't covered. I wanted to give you, so in North Carolina, we have 682,000 uninsured. North Carolina is the number that we have at this time. 48% are people of color. 7 of our rural hospitals have closed since 2010. And the money that's lost so far, so $38.2 billion in federal money from not expanding Medicaid. When you look at the southern states together, I maybe can find that later, but there we ended up looking at all of the impact for all of us and how huge it is for all the states. So that is why when we thought about the opportunity to let our U.S. Representatives know that the southern states need a way to go around sort of this blockade to Medicaid. And that's exactly what we did. So instead of just lobbying state lawmakers, we lobbied our representatives in the federal government to make it more palatable and more incentivizing for our lawmakers here to be able to show their constituency that it is time to do something before we lose more lives. I would end with, you know, Medicaid expansion. Without it, at least 1,000 people are dying every year because they're uninsured. And for me, I believe that doing that for people to die of uninsurance is even crueler than some of the conditions that people have to deal with every day. So thank you for allowing me to be part of this panel.
Thank you, Nicole, and thank you to all our panelists. We've now reached the question and answer portion of tonight's town hall. Our moderator this evening is Velda Jenkins. She is the Chief Executive Officer of the YWCA of the Lower Cape Fear. And in that capacity, she also serves on the New Hanover County Commission for Women. Velda?
Good evening, everyone. And thank you, panelists, for an excellent presentation tonight. It was so informative. We do have a few questions that's coming in to our chat or our Q&A, but we do have some other questions that we would like to ask the panelists this evening. The questions that we're going to be asking are open to anyone. If you feel very strongly about answering the question, please do so. And those of you that would just like to follow up and add to or expand the information that is given by the panelists that's responded to the question, feel free to do so. Tonight we talked about the Medicaid expansion, and we see that the North Carolina General Assembly has not expanded to Medicaid in North Carolina. And we know if they do, there's going to be about 500,000 North Carolinians that would be eligible for Medicaid. From the survey in 2016, it indicated that a little over 10% of the total adult population had no health insurance. To date, as you said in your presentation, 38 states have passed or have addressed Medicaid expansion, and also the District of Columbia. 12 states have not adopted expansion, and with North Carolina being one of those states. Here in North Carolina, is there a logical argument against Medicaid expansion made by those voting against it? And if so, how would we balance that discussion, and why would any cost outweigh the benefits? Does anyone feel like they would like to take that one?
I'll
Michelle?
jump in. Oh,
Okay, go ahead, David.
I was only going to jump in because nobody else was, but
Well, Dave,
yeah.
I can do it if you would like.
The only thing I would say is that, and it's just a cautionary tale, right? Is that, again, I think one of the things we have to be cautious of is not demonizing people who have chosen not to do this over the years. Their reasons, again, they're not the reasons I would agree with, right? But I think what the best thing we can do as advocates is making sure to understand what those arguments are. And I think Nicole made a great point. All of them are easily debated, right, and shown to a different side. But I think if we go at that approach, right, that's the right answer. Because I do believe people want to see a better North Carolina. They wouldn't run for the General Assembly if they chose not to, because it's not like a great paying job or anything like that. So,
Michelle, would you like to follow up on that?
Yeah, I'd add to that and say, the reasons for not expanding that are often cited, legislators are concerned that it will end up costing the state too much money. Because the more people on the Medicaid program, the expectation is the more state dollars that need to be used to cover that portion. For a number of years, the match was at 100%, and then it slowly decreased down, and it is now at 90%. And I would argue that I think there's maybe a potential lack in understanding of exactly what it does mean for state dollars. Without question, the additional federal funding that would come in from Medicaid expansion would definitely free up other state dollars. Right now we have a behavioral health system that is funded entirely by state dollars for folks who do not qualify for Medicaid. And so by expanding Medicaid, which would be 90% federal dollars, that would replace the 100% state dollars that is being used for the behavioral health system. So I think I'll put it down to a lack of understanding of exactly what is involved in terms of the cost. The reduction in uncompensated care also is significant and then ends up freeing up state dollars. The additional funding that potentially comes from the COVID relief bill, I do think is potentially a game changer, because I don't know how you argue with that. There are arguments that expanding Medicaid would prevent people from working. I think the evidence in the states that have expanded is exactly the opposite. In fact, even states that don't have work requirements associated with their expansion have seen increase in employment, and it's because of the increased federal funding that's coming into the state and the impact on economic activity. I also think that this idea that expanding Medicaid and giving people access to insurance coverage would lead them to not working fails to recognize that people have things to pay for other than healthcare. And so they have to have a job, whether they have Medicaid or not. They still have to have a job. They still have to have a house. They still have to have food. And so I just think that it's a false argument that expanding Medicaid leads to people not working.
I'd like to jump in there too. I agree with all of that you just said, and wanted to just bring up the fact that if we had accepted Medicaid expansion in the beginning, it was paying 100% of the cost. So, and then stepping down and ending with 90%. And at that point, it's still a better deal than the 67% that we're getting for the current program. And you're talking about an estimated By 2019, it would have been $2.8 billion, and then climbing to $4.7 billion by 2022. And we're almost hit 20, we're almost there. You think about how fast things are going. And these are pre-COVID-19 estimates. And so it's really hard to argue a misunderstanding of what 100% means. So I have a problem with that, understanding that. And also, that we've had 7 rural hospitals close and some to pull out maternity care out of their hospitals. And so it's hard to understand how that was not a good thing to do, related to a fiscal responsible thing and a morally responsible thing. So I just have to say that, because when you meet mothers who have lost their adult daughters because of substance use disorder, like one who lost her daughter on Mother's Day, and she had to tell her granddaughter that her mother died and accidentally overdosing on Mother's Day. When you try to tell that story, and I accompanied her to speak to lawmakers, it's kind of hard to argue with her. When you talk to some of the people today that we saw, like Amanda, and who is a veteran who's trying to care for her mother. And we've met with veterans who are teaching or learning how to farm, who are teaching other veterans how to farm. And there's still 12,000 veterans in North Carolina without health coverage. It's kind of hard to argue that this wasn't a good idea from the beginning. It was a great idea. Now it's an excellent one.
And then I'd say the last argument that I hear is Medicaid is a broken system. And so why would we expand a broken system? And again, I think that is just a complete lack of understanding, because Medicaid, like literally every part of the US healthcare system, needs improvement, but it is certainly not a broken system. We know that through Medicaid participation, people have access to care, they have access to primary care, they have access to specialists, they have access to hospitals. And so when you even survey Medicaid enrollees about their experience in Medicaid, they are satisfied. In a similar rate to those who are in commercial in the Medicare market. Again, none of our components of our healthcare system are perfect, and so the idea that Medicaid is somehow less perfect, I think, is a false assumption. And so we really aren't expanding a broken system by expanding Medicaid. My perspective is we are investing in a vital system, and by making that investment in Medicaid, we are investing in the stability of our healthcare system overall.
Thank you so much. We have a question that just came in from Q&A, and I think this will come in very timely with the discussion. It says, who currently manages the Medicaid program in North Carolina, and would this change with expansion?
I think it's Dave. Dave manages it.
Our team does, yes, through DHHS.
Thanks, Dave.
Well, it's a great question, and I think it ties in 2 ways. One is that it will still expansion will still be managed through DHHS, and our division is a division of health benefits. We are changing to a managed care system in Medicaid July 1st, and what we envision is that when we expand Medicaid, that we'll use that same managed care system as the delivery system for expansion. It's also important to note is that this move to managed care began in 2013 at the same time when the legislature first said they weren't going to expand Medicaid. And although it's forgotten by a lot of folks, is that one of the things they said is that if we move to managed care, then we'll be able to expand Medicaid. So I think it's a good reminder of folks. And I'll just add one other thing is that Bristol, when people say Medicaid's a broken system, you're absolutely correct, Michelle, is that lots of things that can be improved throughout healthcare, and clearly we can continue to improve Medicaid. But one of the things, another argument is that we had these cost overruns in Medicaid. And important to know, for the past 7 years, Medicaid has actually returned dollars to the general fund at the end of the year because of a lot of reasons, but those cost overrun concerns that people had in the past, I think, are no longer warranted to be as an argument against Medicaid expansion.
Nicole, you had mentioned that there were several rural hospitals that had closed. with these closings due to the financial distress, are the companies that own these hospitals advocating for Medicaid expansion?
That's a great question. There are some entities that have openly advocated for Medicaid expansion, and particularly the North Carolina Healthcare Association has come out and said this will help our hospitals and not just the rural hospitals. In my town role, I understand that the county governments are the places where the human services come from, and so we know that there are a lot of things that our county managers would probably like to put in a budget that they normally have to pay for something else because of not getting revenue from Medicaid. So it's just a win-win for town and county local governments, and especially our hospitals that and some that have not closed are on life support, and it's time to inject some dollars into them so we can make them more viable. And they're also some of the main one of the main drivers of economic activity because it's a place where people work.
Thank you, Nicole. We talked about the 38 states and District of Columbia that have adopted Medicaid expansion. There are a few states that's comparable to North Carolina in size, population that is, that have acted on Medicaid expansion: Michigan, New Jersey, Virginia, and Ohio. How have these states benefited from the expansion, and what can North Carolina learn from them?
I mean, I can start and others can jump in. I would say that that they probably saw more jobs, just like, we know that we've lost out on at this point, probably 37 to 39,000 jobs. And so those states were able to bring in federal dollars. And, one of the moral things is some of the people were able to actually use healthcare, which is what we want people to do. And when people are healthier, then they can be more productive in their communities, schools, their work, and just engage with their families and take care of themselves. Another thing is that they probably are more than likely very much more prepared for natural disasters. We understand when hurricane season is here in North Carolina, but we didn't know anything about COVID season. And so I would say that these states would be much more prepared for a pandemic than we were because they had a mechanism for people to go right into when they lost their employer-sponsored health coverage.
Thank you, Nicole. We are really close to 8 o'clock. I think we have maybe 3 or 4 minutes left. I would like the panelists to have a few minutes to sum up their presentation or give their last words or comments. So we'll start with Dave. Do you have anything you would like to leave us with?
I really appreciate the advocacy work that folks are doing here. And I think what I would say is that we should never give up, right? We've had a lot of years that people have been trying to make this happen. I think this is the year. So an exciting opportunity for all of us.
Okay, Michelle. Thank you, Dave.
And so, like Dave, I'm hopeful that we can make forward progress. I will say that, in my jadedness, because I've been doing this for a really long time, I sort of wrote off the North Carolina General Assembly, but in my hope of a 2021 that is better, I've decided to take a different approach to that, and I would encourage other advocates to do as well, and try to speak to opponents of Medicaid expansion from a perspective that resonates with them. I would like for the stories to be the motivating factor, but unfortunately I find that they're not. And so for opponents of Medicaid expansion, we really need to speak to the principles that are often reflected in political conservatism. So speaking to market efficiencies and how Medicaid does in fact make the healthcare system work better, that it makes private insurance more affordable. Speaking to fiscal conservatism and allowing the state to use its state dollars in ways that the federal funding could not be used for. And then really looking at, what it does for somebody to be able to have access to insurance through Medicaid, for example, starting a new business. One of the stories we did hear about was somebody's trying to start his own electrical company. So, and then employment, the rate of employment that other states have seen. I think these are all important talking points, and we just need to accept that Medicaid does lead to these improvements.
Thank you, Michelle. Jenny?
Yes, plus one to all of that. And I would say that as a 12th generation North Carolinian, I am stubbornly hopeful for this state. I refuse to give up, Michelle. And I think my advice would be that if you are convinced that Medicaid expansion is good for North Carolinians, get to know your legislators and hold them accountable. Elections matter a lot, and we can make it happen, but we have a lot of work to do to turn the tide on Jones Street.
And Nicole?
Yeah, thank you. I guess I want to end with just reminding people that when you hear the stories, you can hear not just the stories and experiences, but you hear their pain. And so what we learned by really having intentional, authentic relationships with people, we call them storytellers, who are most directly impacted, is that you don't just keep them in your head to tell the next story, but they're also in your heart. And so I hope that people will take from what they've heard tonight from all the speakers and then the stories we threw out, is that people really need support. They needed it before the pandemic, and they need it now, and they'll need it when we're on the other side of this pandemic. And so if we are one America, if we are one state, then we all should have access to what we need to be able to not just live, but thrive in our communities and through the rest of our lives.
Thank you, Nicole. We had many, many more questions in our Q&A. So sorry that we couldn't get to your question tonight, but I want to thank the panelists, and now I would like to turn this over to Marla.
Thank you. Well, this concludes tonight's town hall. On behalf of the New Hanover County Commission for Women and the League of Women Voters of the Lower Cape Fear, we thank you for attending today's Medicaid expansion town hall.